Thank you. It's a great honor to receive this award. And on behalf of Kasper, pictured on the slide there, and the rest of the author group, we would like to thank you, Brain and Spine, the official the official paper of EUROSPINE. For the clarity, we have no disclosures. Kasper Friis is affiliated with the Spine Center of Southern Denmark, which is located in the town of Kolding. We serve as the degenerative spine unit for the entire region, and the population base is 1.2 million. It was established in 2009 by merging the orthopedic surgeons from 3 different orthopedic departments. And at the same time, we created the research unit affiliated. Apart from Kasper, the research unit consists of 2 professors, Lea Karian, and a senior researcher, Andreas Andersen, a research coordinator, a fundraiser, and at the moment, 3 ongoing PhD students. Within the last 5 years, 9 PhD students have earned their degree at our facility. We have published more than 60 peer-reviewed papers. And finally, we are hosting the National Danish Spine Registry, DaneSpine. DaneSpine is at the moment the largest patient-reported outcome database in Denmark, with more than 100,000 patients included. It's owned by the Danish Spine Society, and we collect data pre-op, demographic data, surgical reported data on diagnosis, surgical procedure, patient-reported outcome at 3 months, 1 year, 2 years, 5 years, and 10 years, and that includes pain levels, duration of pain, working status, and other relevant factors. Kasper was originally one of our PhD students. And we realized from the DaneSpine data that between 10 and 15% of our patients were unhappy with the results after surgery. And we tried to utilize our big database, and Kasper worked on how, if we could somehow identify the patients that was unhappy. And his first paper published was Applied Machine Learning for Dummies, or spine surgeons, where he tested 5 different machine learning programs and then also 2 conventional regression analysis to see what was the best way or program to get good predictions. And surprisingly, they all came out with the same results, basically. He used this knowledge to propose a prognostic tool risking profile that was used in the consultation based on DaneSpine and data from the consultation. The surgeons had to fill out baseline demographic data like height, weight, smoker, and a diagnosis. And then in combination with the patients and depending on the diagnosis, because this is herniated discs, they had to fill out EuroQual, return to work, pain, duration, walking distance, and also a clinical judgment. And the surgeon had to evaluate or mark how they thought the outcome would be after the patient had opted for surgery. The patients were then presented for these bar charts, where the hope was that when they were better informed they would be more satisfied down the road or opt to stay away from surgery. Having these predictions and the results 1 year down the road, we could look into the reliability of the predictions. And here is walking distance and oswestry disability index. And with AOCs of 0.88 and 79, it's pretty good, but there's still room for improvement. Then we tried to look at surgical gut feeling, a paper that has no home yet. And the gut feeling is, I think all surgeons feel it when they see the patient, but they can't really define this gut feeling. So after they had opted for surgery, we had to put in how we thought the surgery would end up. And most of the patients were on the right hand of the slide. And interestingly, apart from EUROQOL, gut feeling hasn't anything to do with age or BMI or pain. But when we look at the results 1 year down the road, the surgeons are pretty good at predicting the quality of life, but it's hard for the surgeons to predict back and leg pain. So as a conclusion on that study, don't underestimate the value of clinical intuition, and maybe hybrid intelligence where we utilize AI with the DaneSpine data and the gut feeling, we might be better to predict the outcome. Now back to this paper that won the award. When we want to implement true shared decision-making in the clinic, we need to know what the outcome is if the patient opts for surgery or non-operative treatment. And within this field of spine surgery, we pretty much know how it's going if we operate them, because we have got the big databases from Scandinavia, NorthSpine, SweSpine, DaneSpine, and about 85% of the patients, they are happy with the results, but we don't quite know how it's going if we don't operate these patients. We tried to make an RCT at our facility some years back where patients referred to a spine consultant, referred to a spine surgeon with spinal stenosis, where we offer the patients to participate in an RCT where they were randomized either to non-surgical treatment or surgery. We saw more than 100 patients and only one actually wanted to participate in the study because they had been through months and sometimes years of non-surgical treatment, and they didn't want to risk to go for further non-surgical treatment. So the patients were actually past the point of equipoise, so it was not a real choice at the time. So to come around that, we utilized some data from PROPOSE, where we had some patients that we had seen that we didn't want to operate, or the patient opted for non-surgical treatment, but we had data at baseline and we had data 1 year down the road. We could then utilize data from DaneSpine to propensity match these patients, so we at least could level them out at baseline and then follow them 1 year down the road. And this is the result of the propensity match. They're pretty much the same age, gender, smoking, whatever, walking distance, pain, duration of pain, and the results. The top row is the number of patients, the percentage of patients achieving minimal clinical difference. And in the bottom row is self-reported improvement. How do you compare your situation with last year? And it seems like the operated patients actually gain more value than the non-operated. This leads to the ongoing project, Proposed 2, and that's also one of Kasper's projects where he wants to make a new prognostic model based on obviously 100,000 patients with Danish-spine data, but also data from 23,000 non-operated patients with PRO data. The diagnosis is verified with MRI, and we have got PRO data 1 year down the road. And further, the patients self-reported what type of treatment they've had for the last year. And then, of course, the surgeon patient information in the consultation and the gut feeling. And it'll be quite interesting to see if we get better hit rates. Thank you.